Okay, thanks everybody for coming. Let's get started. I'm going to record this, so be careful what you say. So we're going to talk about ankle fractures, and first I just want to review it, and then we're going to go over about 6 or 7 cases. So just to review the ligamentous structures about the ankle, medially there's a deltoid ligament, and the middle portion goes from the tibia to the calcaneus, and then the posterior portion goes to from the tibia to the talus, and the anterior portion to both talus and navicular. Laterally, it's the talofibular ligament. The most common one is anterior, and then the lateral, and then this posterior. So 2 sides. So when you have a fracture of the ankle, it's important to understand the mechanism. I've gotten lazy now as I've gotten older, but I try to remember. I ask them, what did your foot look like when you injured it, because they don't help you understand how to put it back together. The timing, when did it happen, the soft tissue injury, how bad is it, person's bone quality, any comorbidities. Most important are diabetes and peripheral vascular disease. And the common mistake I've seen is someone with an ischemic foot or a neuropathic foot. The ischemic foot never heals. And then you do the surgery, nothing heals, wound doesn't heal, and then you ask vascular. At that point, everything's infected. So, Doug, do you have a rule of thumb of what to do with peripheral vascular paths when they come in with an ankle fracture? Do you get just a vascular consult? Do you get like a Doppler study? Do you just do the surgery and see what happens? Like, what are your thoughts?
If they have palpable pulses, you do the surgery. Sometimes for elective and reconstructive stuff, or people with wounds, a lot of times these guys will study them, and they can actually arterioplasty them for like a diabetic wound, but not so much for an ankle fracture. Ankle fractures tend to be.
Okay, so let me just comment on what you said. So you say, hey Mark. So you say you palpate pulses. But a lot of times you can't palpate the pulse because it's swollen, because there's a splint on. So in that case, do you rip apart the splint? And I would assume you'd have to get one of those little Dopplers from the operating room to listen to the pulse. But you're not going to find it on the floor, so you just do a pre-op. What are your thoughts?
No, I palpate pulses.
Palpate?
I don't palpate.
Okay. All right. So assessing the injury, you have to assess the skin. Obviously, the most common thing with ankles is blistering, the nerves, the sensation, the vasculature we talked about, how bad is the pain, and that's important because the patient may have compartment syndrome, which is rare, and they usually have a deformity. So medially, what's in the medial part of the ankle? It's basically the colliculi. And I thought this was a very good. This is a very good slide because you see the anterior colliculus is bigger than the posterior colliculus, and they're separate. And usually the break is straight across both of them, I think. And you can't really see these intra-op because there's that big deltoid ligament there. So it's hard to say. All you see is the fracture site. There's also there's a deltoid in the inside part of the medial malleolus, which connects to the talus. You see that in bottom left. So here's another view of the colliculus, like bottom right. The anterior portion is somewhat bigger than the posterior portion. And then the other pitfall is the posterior portion is right next to the posterior tib tendon, right? So you can really easily put a screw in the posterior tib tendon, which can cause problems. Have you ever seen that? I've seen a couple cases when I was a resident. The other anatomical structure is the syndesmosis. And the syndesmosis basically connects the 2 bones, tibia and fibula. Hey, Jack. Good morning. And it goes from the ankle all the way up to the knee. And you can see here on the left, here's a high syndesmosis injury. You can also have a syndesmosis injury all the way up, and then it breaks the proximal fibula. So when you assess the X-ray, you look at the tib-fib overlap, which is right here. It should be 10 millimeters, and then the clear 5 millimeters, and also if there's any talar tilting. The mortise view gives you a sense of the ankle joint and if there's any widening. The talocrural angle should be between 8 and 15 degrees, which is the tibia, and from the two malleoli. So what happens is it shortens or it can be angulated. The other thing is the fibula can be shortened, and supposedly you can assess it intraop. There should be a dime should be able to be placed there. Do you guys use this test intraop? Do you think of it? Does anybody think of it? Do you, Mark? Okay. So what is that? That's the cover of Mary Shelley's Frankenstein, and I just read it like 2 weeks ago. And it's a story of someone who did an anatomical experiment and took a lot of body parts together and made a human being. And it was like the crossroads of like romanticism and empiricism. Some people felt there's too much science going on. So this is relevant because that's the log Hansen, how we characterize ankle fractures is through the log Hansen experiment, where they took, I think it was like 200 cadavers, and they broke their ankles, just like set them up and just broke them. Set them up either in supination or pronation, and then just externally rotated it or adducted it and broke the ankle. So it's kind of like a hard sort of behavior if you think about it, just like Mary Shelley's Frankenstein. And yet that's how we get the understanding of ankle fractures. So the other recent article that you may have seen is the abduction force is probably responsible to how high the fibula fractures. So if there's a greater abduction force, you get a higher fibula fracture. So that, did you guys, everybody read the article I sent on the email, right? So kind of, it was a Hopkins. Did you know that, Mark? Did you see that email? The Hopkins professor who wrote it? I didn't recognize the name.
The only one that I got was the complications one.
Oh, okay, it must have been another one. Okay, so let's just go over them. Supination, external rotation is the most common one. You can see here on the right the foot's supinated, and it starts. The injury starts anteriorly at the talofibular ligament, anterior tib fib or talofibular ligament. The fibula fractures, the posterior malleolus fractures, and then the deltoid can tear or the medial malleolus can fracture. So it goes from lateral to medial in severity. And the most common one everybody sees is the anterior talofib ligament tear of an ankle sprain. So that's like the most common one. So here's a common stable. Well, what do you think, Doug? Is it stable or unstable? This is a supination external rotation injury. You can see because the fibula starts from anterior inferior to posterior superior. So stable or unstable?
It's a stable injury.
And why do you think it's stable? What's the basis of your answer?
The peroneal tendons tend to hold that posterior fibula in place. It's stable, but it is displaced slightly.
So why? So you explain to me why it's stable, but how do you know it's stable? For Mark, because Mark doesn't have a lot of experience, and he needs to know. So he's going to say, "Well, I want to fix it." He's got a lot of overhead, and he gets $800 if he fixes the fibula.
Like I said, it is displaced, and in certain patients it is fixable, but it's stable because the force is actually acting on this.
But what do you see on the X-ray that makes you think that? That's my question.
It's a long oblique fracture, so actually its obliquity would contribute to.
Okay, so it's not a comminuted one, which would make
Correct.
you think.
Not comminuted, not
So it's non-comminuted, it's long oblique,
contact.
bones intact, looks like two pieces. Also, like the mortise and the
Mortise is intact.
mortise is intact, joint symmetric, right?
The fracture goes below
Fracture, what's that?
Goes right into the.
goes below the tibial ligament for the most part. I think it's the stabilizing force. So I think you can
Okay.
survive it.
Okay, how about this one? You get the lateral injury. Is this stable or unstable, Doug?
Is that the same injury?
Different injury. Medially, What do you think?
So there's a deltoid ligament and there's a shift of the
Because it's the whole talus is shifted lateral, isn't it? And the
Yes.
medially is open, and you have the same fracture, but now it's displaced, and the tibia is definitely not aligned up with the talus. So this one will be sloppy. So here's another different injury: supination adduction. So you can imagine the supination part makes the transverse fibular fracture, and then the adduction part jams that talus, the medial part of that talus, right into the tibia and causes that shear fracture. So it's a little bit of a different injury. So lateral, sorry.
Still stable.
Okay. I'd probably fix it, but I don't know.
Screw across, but basically, by your definition, I think it's stable.
Probably. I think it would do better. Well, you could treat it closed if you want. So here's a pronated foot, and then the other type of injury now is pronation external rotation. So first the deltoid teres, medial malleolus injurious, then the anterior tib fib, fibula, posteriorly, and it goes from medial to lateral. So what makes you describe this one, Mark? What do you think?
It's an unstable fracture that needs to be fixed.
Okay, and just tell me how would you fix it?
It's got a syndesmotic injury,
Uh-huh.
so I wouldn't probably worry too much about the medial side as long as the deltoid's not stuck in the joint.
Uh-huh.
And
I used to have a professor at GW. He used to open every single one just to make sure there's no cartilage and make sure there's no cartilage or joint abnormalities there. So you never open them?
immediately you reduce
Immediately.
it, and then you're sitting there and it's still alive, and then you can open it.
But as long as it reduces, you don't open it. Okay.
So like fibula and syndesmotic.
Okay.
On that injury, the deltoid is always in there. Depends on whether you want.
Deltoid's always in there?
I don't open all of them, but if it's obvious, that's one thing. But anytime you go into open up that side, the deltoid is always flipped underneath.
Okay. Maybe just when you reduce it, it just goes to where it should be. Okay, pronation abduction is a transverse medial malleolar fracture, posterior malleolus fracture, or the tib fib ligament posteriorly, and then the fibula fracture is way proximal to the mortise with a butterfly fragment. So these are usually higher level injuries. So it goes from medial to lateral. Pronation abduction, medially there's a transverse fracture, laterally there's a transverse fracture. So the other way to describe them are Weber. Do you guys describe them in your minds? Do you think of them in Log Hansen or Weber? What do you, Doug?
Weber.
Weber?
Both.
Mark? Both?
Yeah,
How about you,
most
Jack?
The fibula is a Weber, but none of the systems have any prognostic value.
Okay. How about you, Jack?
I got a lot of hands, but I also have basically just try to simplify it.
Simplified.
Make it so,
Busted up ankle?
yeah, something like that. But I mean, I think you look at the level of the fibula,
Mhm.
you look at the
If you do level of fibula, you're basically Weber.
the deltoid ligament, whether the fracture of the medial malleolus is below or above the plafond, and whether the tibiofibular ligament is torn.
Okay, that's very reasonable. So Weber A is below the ankle joint, B is at the level, and C is above. So the other one is posterior malleolar fragment. That's another issue. And what does the posterior malleolus do? It keeps the talus from going posterior. So I had a terrible case of that recently, where I just could not reduce the fracture whatsoever until I fixed the posterior malleolar fragment, like intraop. It just kept sliding backwards. It was the worst case I've ever seen in practice, and I had to fix that first. So most of these posterior malleolar fragments are posterior, lateral, and oblique, 67%. This is from an article in 2006. 19 and 14% of them are just a fleck of bone. or a shell, and the other one goes medially as well. So the medially ones, in my mind, they're a little bit more like a plafond fracture. So, who do you guys have any rules of thumb for fixing them? Mark, rule of thumb?
I was always, if it's 25%.
25%.
More, but I was just on a webinar last night with all these ankle guys.
Do you do a lot of webinars, by the way?
Yeah, and they said that they fixed them all now because that posterior tib-fib ligament, they say is critical to reducing if there's any kind of syndesmotic involvement. They always say there's some level of syndesmotic injury.
Yeah, I was thinking the same thing in my simple mind. Yeah, in that one case, I could not reduce the fracture closed unless I fixed it first. So my mind is like, why don't I just fix all of them? It probably gives some stability and probably at some level protects your implants. So there's a lower chance that obviously there's some risk. You could spear the EHL, I guess.
When I fix them, I always fix them posterior.
Posterior to anterior.
No, yeah, posterior. I directly visualize the fracture, I reduced it, and I put 2 screws in.
You open it up.
Open it up. Yeah, and
From a medial approach or lateral approach?
posterior lateral, and I extend the incision, and I posterior plate the fibula. It's a great operation. It's a great approach.
Okay.
It's very limited, though, and I've seen, and the thing that started my interest is reviewing a few cases where people tried to fix them anterior, posterior, and they couldn't catch that fragment, or they couldn't reduce it, and actually sort of making it worse.
I think a lot of people just miss it. They don't get a CAT scan. They don't know what it looks like, and they
Right.
just they put a screw there.
If you're not comfortable with it, it's a little difficult. But you put the patient's prone, and you just do a posterior lateral incision, and I've sort of worked at it where I can plate the fibula.
You do the whole case prone?
Yes, plate the fibula and plate the screw, fix the posterior movements. But I'm not so sure if I agree with fixing all of them either. Because there's no literature that really shows
Sometimes you got to go with what your heart says,
any
though.
outcomes on any of this stuff. The most recent article that I read was talking about fixing the syndesmosis, and the outcome study showed that there's no difference in fixing the syndesmosis and an SE fracture, which is 87% of all ankle fractures. It's just if you reduce it, there's no difference whether you fix it or you don't fix it.
I know that Barack says you got to have evidence in everything you do, but sometimes you got to do things for what you think is right. I mean, within reason. You know what I mean? Like jumping out of airplanes. The common thing we always say is there's no literature that says jumping out of airplanes is safe. The study has never been done, without a parachute. So you don't really need the parachute. It's never been proven you need it.
It's never been proven that operating on appendix is safer than not operating on an appendix. But
That's what I'm saying. Like you can't base all your thoughts on literature, even though Obama wants us to do that.
okay, so go with me the other way then. If it's no better to fix the syndesmosis than it is not to fix the syndesmosis, you're just doing it on what you feel.
I don't know if I believe that. In my mind, fixing the syndesmosis, I have a very low threshold.
Reduces anatomically, it's like an ankle sprain. And I don't know anyone in this country that fixes ankle sprains.
Yeah, but like everything in life, there's risk-benefit ratio, right? So like if fixing the fibula, if fixing syndesmosis,
If it's my ankle and it reduces, I'll take the risk of non-operative treatment because I know that 4 or 6 weeks down the road, I have the option of having it reconstructed, and the results are just as good as having it reconstructed.
the syndesmosis.
Absolutely.
Oh, in my ankle, I want that screw.
Okay. Just
I don't want-
tattoo it on there, and I'll be glad to put them in there.
I would disagree with that, actually. I think if you have a syndesmotic,
Who do you disagree with? Okay, go ahead. You're smart. Go ahead. What is it?
I think if it was my ankle and I had a widened distal tib fib there, I don't know that you need to operate on it to fix it, to sew it over. I think you need to stabilize it with a screw across the
What do you lose?
You don't need to stabilize it, you need to reduce it. And if it reduces anatomically, there's no difference between fixing it and not.
Yeah, but if it's
Long-term studies do show that it widens.
also look on the table, it's reduced. But a guy like Jack, he likes to drink whiskey. He may go dancing the next day.
And you know
Like that's
what?
Harford County guys, and they're
you
going
know
to
what?
displace.
You put a screw in it, it will displace.
No, the screw, he'll be good. He'll be like
Hey, it
dancing.
feels pretty good.
Yeah.
I'll give you the article, and you can But, you know, the best way is, sometimes the best way is to look at some of this stuff, and if you want to fix them, my personal take is that is that
Too many people fix them.
Syndesmosis is overfixed, and people just don't have they say it's stable, but it's not moving, but I'm fixing it anyway.
What do you mean by fixing?
How do you
Putting
Put
a,
a screw across?
screw across it, right?
Or do you go in and actually sew it?
no, Syndesmosis,
Which is impossible, by the way. I know.
A screw. Let me ask you another thing. How do you guys test it? Mark, how do you test it?
I just do get a mortise view and then
Externally
externally rotate.
rotate?
And then I've been doing the lateral AP translation to see, because they say that's a little bit better sensitive test.
What do? You get an AP view, and then what do you do?
I do the mortise view, I do the traditional kind of
External rotate?
Or external rotation, and just see if it opens up. But I also have been taking a lateral and pulling it up and down.
So you get a lateral X-ray, and you shuck it anterior, posterior, like a drawer test. And if it shifts, then you put the okay. That's good. Do you do the fibula? You put a clamp on the fibula and pull it lateral. I don't do that, but okay.
Fix it with dorsiflexion? Fix it.
Don't ask Doug that because he says there's no evidence it helps. But I dorsiflex them. I dorsiflex them, and when I do that, it's like when I sin, I say, "I'm sorry, I'm sinning, Doug, but I'm still doing it." It's like when you sin, you ask Jesus for forgiveness immediately.
that's okay.
I do. I think as Doug thinks this is wrong, but I still do it anyway.
Go back to posterior malleolus. I mean, if you have basically a 25%, that's still, I think the secret of that is to dorsiflex the ankle, because, 75 or 80% of them will reduce just by dorsiflexing the ankle. Reduce that fragment in a millimeter. Just make sure that they're casted.
And then you don't fix it. So you won't fix a posterior malleolus that's 25%, but you'll fix a syndesmosis that's reduced.
And torn, yes.
Okay.
I fix both.
Okay.
Yeah.
I fix both because I'm a spine surgeon and I like to put screws in.
There you go.
Okay, so syndesmosis.
Makes a difference.
Yeah, we talked about that. So here's some variants. Maisonneuve fracture, the high fibula. These are some nice words for you guys to remember. A Volkmann's fracture is the tibial attachment of the posterior inferior tib fib ligament. Wagstaff-Lefort, which is rare. It's the fibula fractures anteriorly. And Tillot-Chaput is the ones, I just call it Tillot, is the anterior lateral Tillot-Chaput fracture. And the opposite side, if it breaks off the fibula, that's called the Wagstaff-Lefort. So collicular fractures we talked about, anterior, posterior. So operative approaches we talked about. We all know these. The medial approach, it's just a saphenous nerve really. It's the only thing that you can really injure, and if you injure it, it's not a big deal.
There's one thing about colliculus fractures.
Go ahead.
They're supposedly highest associated with snowboarding injuries.
Snowboarding?
Snowboarding injuries.
Okay, that's
So if you
interesting.
know someone has a snow and you can't figure
I
out...
thought talar necks were the snowboard injury. Colliculi? All right. So lateral approach is a superficial perineal nerve. Do you guys have any ways to avoid injuring it? So there's always a chance that it's supposed to exit the lateral perineal musculature compartment 11 to 14 centimeters above the ankle, which is way above most ankle fractures. But it can exit distally. So do you guys have any rules of thumb how you avoid injuring it to share with us? Mark, you know everything.
I just look for it.
You just look for it.
Dissect.
I have the Spiro technique. Is I just cut the skin. I just use my thumb. I figure my thumb's not going to tear the nerve usually, and I use my thumb to get all the way down to the fibula. And I've gotten a couple like this. Okay, so how do you fix the fibula? You can just use 2 screws. You can use a plate and a lag screw. You can use a gliding plate. You can put the plate posterior. How do you fix medially? You can use a tension band wire. You can use 2 parallel screws, which is how I was trained in most of my cases. Or you can use a plate and screw combination. Does anybody use anything different? Okay, so how do you fix Huh? What's that?
Covered everything, didn't anything different.
Yeah. Posterior malleolar fragments, I just use cannulated screws, but Doug uses the posterior plate, which is, actually next time you do one,
I do screws.
you do screws too?
Posterior ones, yeah.
When you're going to do posterior plate, tell me, I'd like to see it if I'm around. So how do you fix a syndesmosis? You can just do one single screw 3 cortices. You can use one single screw 4 cortices, 2 screws 3 cortices each, and 2 screws 4 cortices each. What do you guys? I'm just curious. What do you guys use? Mark, what do you usually do?
I do 2 tricortical screws.
Really, 2 tricortical. How about you, Doug?
1 or 2 tricortical screws.
1 or 2 tri. Any literature to support that? I'm just messing with
The
you.
disadvantage of doing a tricortical is there's a high breakage rate
Right.
historically. And so what happens is
And then you can't fish it out.
If it's 4 cortices, you can fish it. It's easier to get out from the medial side.
Right.
Whereas if it's 3, you're stuck.
Yeah. How about you, Jack?
Single screw, 4 cortices, and if it breaks, so what?
And I tell the patient it's going to break.
Yeah.
I'm the same way. Me and Jack like single malt scotch, and we do the same thing as syndesmosis screws.
Well, I mean, we used to sit there.
You guys should get together more often.
I know we
Maybe you
should.
are.
We actually, whenever we're together, we have a good
Have a
time.
Scotch tasting one of these things, but anyway. But there's been a few, we used to take them out.
When do you take them out?
1 month, 2 months, 3 months,
Yeah.
whatever we decided to do at that time. Because we say, well, it's going to break sometime, but we all have patients that came back, it's broken, we took out the proximal fragment. And so what?
Tell them it's going to be in there
So
for
my-
life.
My criteria is let it break.
Yeah.
Because they're all going to.
I tell everybody it's going to break, and probably.
They break, come back, we'll take it out. You can take it out in the office.
It's the only time they break is when I don't tell them it's going to break. Then it breaks when I don't tell them it's going to break. Okay. Okay, so let's do some cases. Mark is a 20-year-old man who trips and falls, injures himself. What do you do? What do you see on the fracture first? He's reduced in the ER. Bimalleolar fracture, unstable injury. You just send him home, do him next week?
Yeah, I mean, depends on the swelling. You can do it the day of if he's not super swollen.
Okay.
If he's swollen or has any soft tissue problems.
And do you always try to put a lag screw in the fibula or not? Sometimes just plate it.
Depends. I'm pretty much a lagger.
You're a lagger. And how about medially? What are you going to do here? Tension band, plate, 2 screws?
I'll usually use 2 screws.
2 screws.
It's more of a vertical shear than I'll put on one of those little wide plates.
Okay. So this is kind of what you would do. Okay. Next one's Doug. This is a
That's such a small fragment.
medially?
Is that yours?
No.
No. That's such a small fragment immediately. A lot of times you can break that.
Yeah, I've done that before, and then you got nothing.
It's also below the plafond, so reducing it, and fixing the lateral side, the medial side actually would heal fine. I think it looks good. It's probably not.
I would feel uncomfortable not fixing it.
Well, I mean, you'd like to, but I think but it's stable. It's a stable medially stable.
That mortise looks shifted to me, pre-op.
No, it's shift, but the plafond is there, so when you move it
I don't know.
medially,
It looks like you have a good tip-fib space
you're
and
not
it
going
clears.
to dislocate the ankle immediately.
Maybe. I mean, you test it. Don't you test every ankle? You just put it on the AP view and just test it with external rotation. It takes 2 seconds.
No, I think it's shifted, and I think you'll correct it when you fix the fibula, and it looks,
Yeah.
if the post-op x-rays are the same, it looks anatomical.
Yeah, you get this in drop and then do external rotation and see if you can shift this syndesmosis. If you can't,
But
done
you
deal.
can see that on that middle film, there's calcification in the syndesmotic space,
Yeah,
indicating that there was a syndesmotic injury there,
yeah, yeah,
and it wasn't fixed.
yeah.
Syndesmotic screw.
Yeah, no literature to support it though, right? We're evidence-based doctors.
Would you put a screw in the syndesmosis?
On that one?
Not if it's stable.
No, I wouldn't. But there was definitely an injury there.
Yeah.
Some level of injury.
Yeah.
All right, Doug, next case.
I think it's reasonable to.
Reasonable. 15-year-old with a fibula fracture, slip fell while dancing.
Is that all I get?
That's all you get.
It's a
AP film's normal.
It's a displaced fibular fracture.
Yeah.
It's a
The level of the ankle joint.
it's like a Weber B.
Uh-huh.
You know,
Cast.
Excuse, there's no good literature, but if it's a,
We got 8 cases to go through, so let's be
I
quick.
would fix it.
Okay.
I have
With
a low threshold for fixing.
lag
displaced
screws and
fibular
plate or no?
fracture. I'd probably just do posterior plate.
All right.
Anti-lag plate.
This guy did the anti-glide plate. I never put these in, but
That's what I do as many of them as I can in that preferred treatment.
okay. Let's Jack, 40-year-old man with a this unstable fracture, fibular fracture, transverse, pronation, external rotation injury, medial malleolus fragment. What do you do? Long leg cast?
At least. No, I think you have to fix the
Fix the fibula.
And put a screw in the syndesmosis and fix the medial malleolus.
Okay, because the tibia and the fibula are pretty wide, and you put a screw in the syndesmosis.
You don't have any choice.
Okay, this person just did a three hole. Okay,
There's a guy, there's a book, there was a guy named Isidore Yablon, who was from Boston, who wrote a book on ankle fractures, and I tried to find it this morning, but it was the best book I ever read on ankle fractures.
oh, email me the thing. I'd like to
But his
email
cri-
me the name.
But his criteria was basically the fibula. It says if you fix the fibula, some of the things that you mentioned, if you fix the fibula is a stabilizing force of the ankle.
Fibula
The medial malleolus
is the most structural.
It's nice there, but it says he fixed the fibula, and he was very aggressive as far as the
Fixing every
one that
fibula.
you had before that had the displaced fibula or oblique fracture. He would automatically fix that.
Fix the fibula.
Fix the fibula.
If you would take anything home from this conference. Okay, next, Mark. 75-year-old woman who slipped and fell after she won at bingo. She got really excited and she jumped up and ran to collect her prize, slipped and fell. What are your thoughts?
Not great x-rays, but obviously unstable.
I apologize about all the x-rays. It's not my fault. It's Eric's fault. But go ahead.
Scotch.
She's subluxed and it's unstable, so fix it.
Okay, do you do what Jack said? Fix the fibula first or no?
Yeah, I mean, I can't really tell. There's probably a posterior mal component to that, but
Oops. Okay. Do you get a CAT scan on these cases or no? Sometimes you don't see a good x-ray. Get a CAT scan?
I don't know. I've been getting a lot of them.
Okay.
I'd rather know if there's like some combination in there, really be able to quantify that posterior.
I have a low threshold for CAT scans. Okay, so this is what I did in this case. Fixed the fibula. Immediately, there's like a tiny little fragment. And I had to know that, I think, from the CAT scan. So I did not open immediately, and I put the syndesmotic screw. And do you think my plate's too long, Mark? Would you have done a shorter plate?
You know, it looked like it was a pretty oblique fracture, so.
You wouldn't criticize me for that. Now, my thoughts, I'll tell you, I try to do things for reasons. My thought is more points of fixation, the better. These elderly people who have very soft bone, yeah.
Absolutely.
So more points better and less pressure.
Even if the bone really is bad, these guys last night were saying just put it into the tibia. Put it
Right.
in the screws.
Do a
It's not, I mean, you got the syndesmotic screw in there, but even higher up.
We call that, in Hartford County, we call that the George Papyrus technique.
Right.
He invented it. And then these guys said that they invented it. Go ahead.
Technically, the screw is too high. You want to have it at
Oh, where should it be? 1.5
physeal-
centimeters?
Well, you want to have it ideally at the physeal scar, number one.
That's about 1 centimeter. 5 millimeters?
And, the problem that you can get with this is sometimes when you put that screw in, you can distract the fracture. So I've seen a lot of those where, the fibula is fixed straight, and then guys like put a couple of screws.
You don't
in
lag
this.
the syndesmotic screw. I've
Right,
made
all of a
that
sudden
mistake,
it's
yeah.
working the thing. And
It's a
if you-
neutral screw.
And some of these, when guys look at these with CAT scans post-op, they see that the syndesmosis, it's a sigmoid notch, and a lot of times it looks absolutely perfect, but the fibula is so anterior or posterior, or you can.
Let me show you. That's a very good point, Doug. Let me show you. Do you guys, everybody understand what he's saying? Hold on. Shoot. this is too long. But right there.
Yep.
See what he's saying is that it's the fibula's got to fit into that notch. It's a very good point. And you can have that shifted. Okay. I remember reading that once, and I've totally, like, probably 20 years ago, and I forgot, and now it reminded me of it. Okay, where were we?
Which is another reason for fixing the fibula anatomically.
No, well, yeah, but Doug says there's no literature, so I'm not doing it anymore. All right, who's up to bat now? Doug?
Sure.
Doug is, this is a 40-year-old man who was riding his motorcycle. He was looking at a pretty girl, and he fell on Bel Air Road. You know, it's getting warm out, and she was wearing, you know, how girls in Hartford County are. They wear these sexy things.
Don't go there.
Okay, all right, I'm sorry. Go ahead.
Pretty girls have got it.
He's got a,
All right.
he's got a what looks like a bimalleolus fracture,
Okay, bimalleolus, that's not good.
and it's a there's probably an injury to there is an injury to the syndesmosis, and there's a tibio-talar shift.
At some level, right? The clear space looks open, doesn't it? It's more than 5 millimeters.
Yeah.
Okay, and the tibia fibula space is less than a centimeter. Okay.
Yes.
All right. So how do you fix it? Immediately, laterally first, fibula, prone position,
No.
lateral,
Yeah, I do them lateral, and I try to fix the fibula.
lateral
first.
position with a beanbag. Is that what you do? That's what I do too. Okay.
And I try to fix the fibula first.
Okay.
And, you know, I'm concerned about the imaging. It almost looks like he has a talar dome injury.
He does.